Assalamu alaikum now. Now I would like to discuss about an important topic of obstetrics, that is breech presentation. Okay, there are three types of breech: frank, complete, and incomplete. Frank breech, complete breech, and incomplete breech. The frank breech, hip and knee. Hip is flexed, knee is extended. So for frank, hip, knee. For frank, hip is flexed and knee is extended. That means buttock presentation. Incomplete, both hip and knee flexed. And for incomplete, one or both hip not flexed. So one or both hip not flexed. So this one for frank, hip and for frank, hip is flexed. For complete, again hip and knee is flexed. And for incomplete, one or both hip are one or both hip not flexed. One or both hip not flexed. That means feet presenting. And this frank is buttock presentation. Buttock. Risk factors is advanced maternal age more than 35. It may be multiparity, uterine didelphus or uterine didelphus, septate uterus, uterine leiomyoma, fetal anomalies, anencephaly, preterm less than 37 weeks of gestation, oligohydramnios or polyhydramnios, placenta previa. Management is ECV, external cephalic version, and caesarean section. External cephalic version and caesarean section. This is frank. So in frank, look at the hip and look at the knee. Extended, hip is flexed. For incomplete and the complete, look at the complete first. Incomplete, both hip and knee is flexed. For incomplete, one or both hip not flexed. One or both hip not flexed. This is single footing. This is double footing. Single footing and double footing. So frank can try vaginal. Frankly, you can try frank, and for complete can try vaginal, but for incomplete, footing, vaginal, footing, and the incomplete, that means uh, one or both hip not flexed. Caesarean section should be done. What is the preterm? What is the recommended management for a pregnant woman at 35 weeks of gestation? Pregnant woman at 35 weeks of gestation that presents with preterm labor in the fetus in breech presentation on ultrasound. In breech presentation on ultrasound, that is cesarean delivery. Betamethasone with or without penicillin may be administered. If vertex presentation on ultrasound, if breech, then betamethasone. Okay, now what is the recommended management for a pregnant woman? What is the recommended management for a pregnant woman at 35 weeks of gestation that presents with preterm labor with the fetus in breech presentation on ultrasound? With the fetus in a breech presentation on ultrasound, that is cesarean delivery, betamethasone with or without penicillin may be administered as well. Betamethasone with or without penicillin may be administered as well. If there is vertex presentation, expectant management. So B goes with the C, that means breech, cesarean, preterm breech, cesarean. If vertex, VE vertex, expected management. Active liver is a contraindication of ECV, external cephalic version. Active liver is contraindicated. What is the management of breech presentation or transverse life? What is the management of the breech presentation or transverse life? Less than 37 weeks, no intervention, as most fetus spontaneously convert to cephalic. So for breech and transverse less than 37 weeks, we do not need to do any sort of conversion. No intervention is needed. For more than 37 weeks, ECV, external cephalic version, more than 37 weeks, no active labor, no fetal distress, cesarean section if fails. Caesarean section if fails. External cephalic version. External cephalic version. Okay. External cephalic version, there is manual rotation of the fetus to the cephalic presentation. Manual rotation of the fetus to the cephalic presentation, and it decreases the caesarean delivery rate. It decreases the caesarean delivery rate. It is indicated for breech or transverse and more than 37 weeks of gestation. Absolute contraindication. Uh, absolute contraindication is contraindication to the vaginal delivery prior classic cesarean section, prior extensive uterine myomectomy, prior classic cesarean delivery, prior extensive uterine myomectomy, and if there is placenta previa. And the complication is abruptio placentae and intrauterine fetal demise. Abruptio placentae and intrauterine fetal demise. Contraindication to external cephalic version. Contraindication to external cephalic version. Indication of the for cesarean delivery regardless of fetal life failure to progress during labor, non-reassuring fetus, and placental abnormality, placenta previa or abruption. There may be oligohydramnios, rupture membrane, hyperextended fetal head or fetal or uterine anomaly, and multiple gestation, active labors. So these are the contraindications of the external cephalic version. Contraindications are indication for cesarean delivery regardless of the fetal lie, failure to progress, non-reassuring fetus, placental abnormality if there is placenta previa or abruption, if there is oligohydramnios, rupture membrane, hyperextended fetal head, fetal or uterine anomaly, and multiple gestation. This is external cephalic version. Okay, this is breech or buttock presentation. So we are turning the patient into transverse, then we are turning the patient into head position. So this is cephalic position. It can be done manually. So what is the next step in the management of a healthy pregnant at 37 weeks of gestation that desires a vaginal delivery? Ultrasound of the fetus is in frank breech presentation. Frank breech presentation. Ultrasound reveals the fetus in a frank breech, that is external cephalic version, can be attempted in women with breech pregnancy at more than 37 weeks of gestation if there is no contraindication of the vaginal delivery, and if there is and the fetus is in good health. This is internal podalic version, breech extraction of the secondary twin. Place the hand in the uterus, place hand in uterus, grab fetal foot and deliver baby feet first. Okay, then head. Now this is shoulder dystocia. This is shoulder dystocia. Okay. Mm, Shoulder dystocia, failure of the failure of usual obstetric maneuver to deliver fetal shoulder. Failure of obstetric maneuver. Failure of usual obstetric maneuver to deliver fetal shoulder. It may be due to fetal macrosomia, big baby, maybe maternal obesity, excessive pregnancy weight gain, gestational diabetes, postpartum pregnancy more than 42 weeks. Warning sign is protracted labor, protracted labor, retraction of the fetal head into the perineum, retraction of the fetal head into the perineum after delivery, turtle sign, retraction of the head into the perineum after delivery, that is turtle sign. This is mm, shoulder dystocia, Mac Roberts maneuver, legs flexed onto abdomen and causes the rotation, leg flexed on the abdomen, causes the rotation of the pelvis and alignment of the sacrum and the opening of the birth canal. Suprapubic there may be suprapubic pressure applied to fetal anterior shoulder. Okay, these are the complication can happen in shoulder dystocia, fracture clavicle. So first clavicle, then humerus, abducens palsy, Klumpke's palsy, and perinatal asphyxia can happen. Fracture clavicle can be diagnosed. There is clavicular area, there is crepitus or bone irregularity. There is decreased Moro reflex due to pain on the affected side, decreased Moro reflex on the pain on the affected side. There is intact biceps and the grasp reflex. Intact biceps and the grasp reflex. In a fracture of the humerus, there is upper arm crepitus or bone irregularity, upper arm crepitus or bone irregularity. There is decreased Moro reflex due to pain on the affected side. Mm, Decreased Moro reflex due to pain on the affected side. Intact biceps and grasp reflex. Abducens palsy, decreased Moro and biceps reflex on the affected side. Decreased Moro or biceps reflex on the affected side. Waiter stiff, extended elbow, pronated forearm, flexed wrist and finger. There is intact grasp reflex. In fracture humerus, there is intact grasp and biceps reflex. And in fracture humerus, there is upper arm crepitus. Klumpke's paralysis, there is claw hand, extended wrist, hyperextended metacarpophalangeal joints, flexed interphalangeal joints. There may be absent grasp reflex. There may be Horner syndrome, intact Moro or bicep reflex. Perinatal asphyxia, variable presentation depending on duration of the hypoxia. There may be AMS, alternate mental status, port tone, seizure. In ARBS and Klumpke's paralysis, management involves observation alone. Most infants recover are function spontaneously within a few months. Okay, for management of the shoulder dystocia, be calm, breath, don't push, elevate leg and flex hip, thigh against the abdomen. Call for help, apply suprapubic pressure, enlarge vaginal opening with episiotomy and the maneuver, deliver posterior arm, rotate posterior shoulder, deliver posterior arm, rotate posterior shoulder, Wood's screw, apply pressure on the anterior aspect of the posterior shoulder, adduct posterior shoulder. So rotate posterior shoulder, adduct posterior fetal shoulder, and this is called Rubin posture. And mother on hands and knee, all for Gaskin posture. Mother on mother on hands and knees, all four, and replace fetal head into pelvis for cesarean delivery, that is Javanelli procedure. So become breath, don't push. Elevate legs and elevate legs and flex hip, thigh against abdomen. Call for help. Apply suprapubic pressure, enlarge vaginal opening with episiotomy, and there is maneuver. So this is all about shoulder dystocia, breech presentation, external and internal cephalic version. Okay, hope you enjoyed.